Hello everyone, and welcome to your last class in Nursing 181. This is your GI and GU lecture, and I hope you enjoy the online format. Okay, so before we begin, we're going to go over a little bit of terminology regarding nausea and vomiting. Nausea, hopefully you've all, well, maybe not hopefully, but I'm sure you have all experienced this at some point. And this comes from the Latin nos, meaning a ship. We know it's a very unpleasant sensation, and it's a feeling that one may soon vomit. Retching involves muscular activity of the abdomen and thorax, and it's often voluntary, leading to forced inspiration against a closed mouth and glottis without any oral discharge of gastric contents. Another name for this are dry heaves. And then vomiting, we know, is also known as emesis, involuntary contractions of the abdominal, thoracic, and GI muscles, which are smooth muscles, leading to forceful expulsion of stomach contents from the mouth. Okay, and then regurgitation is an effortless return of esophageal or gastric contents into the mouth, unassociated with nausea or involuntary muscle contractions. Sometimes you hear people say, oh my gosh, I just vomited into my mouth a little bit. It's like all of a sudden this gastric contents comes up, and that can happen to anyone occasionally. Okay, types of vomiting. Projectile. This is forceful, tends to shoot across the room, very common in infants, and it's usually associated with an obstruction near the pyloric sphincter. And with infants, it's usually related to pyloric stenosis, which is very common in newborn babies. Intractable is persistent, uncontrollable vomiting. Psychogenic is vomiting that occurs with emotional stress. This is not causing weight loss specifically. This usually occurs during meals because of strong emotions. And then self-induced vomiting is associated with purging disorder. This is an eating disorder where the main characteristic is recurrent purging in an attempt to prevent weight gain. This is different from bulimia because they do not participate, usually, these patients, in large, out-of-control binging. And then stercoraceous is vomiting of fecal matter, and this generally occurs with some type of bowel obstruction. The causes are many. You can probably think of quite a few on your own. The first one that people tend to think of is medication, specifically cancer, chemotherapy treatment, but some other drugs that can cause nausea and vomiting are metformin, anti-Parkinson drugs, many analgesics such as opiates, NSAIDs, digoxin, antihypertensives, antibiotics, especially erythromycin, oral contraceptives, anesthetic agents, and of course syrup of ipecac, which we will give oftentimes to children to induce vomiting if they've swallowed something that's poisonous. GI problems such as gastritis, gastroesophageal reflux disease, gastroenteritis secondary to viral or bacterial ingestion of some type of organisms, migraines, inner ear problems, alcohol intoxication, pregnancy, heart attacks, brain tumors, or anything really that causes increased intracranial pressure, radiation poisoning, hypercalcemia, hypo or hyperglycemia, overexertion, someone who exercises too much, food allergies, in particular milk, any disagreeable sights or smells or thoughts can induce vomiting, such as, foul odor of or decayed flesh, things like that. Feces. Some people will vomit just thinking about vomiting. Some people will vomit just listening to somebody else vomit. So some people just vomit very easily, and some people it's very difficult for them to vomit, and they literally have to self-induce and put their fingers down their throat to vomit. The color of vomit is very important as well. Bright red usually indicates bleeding from the esophagus. We call this hematemesis, Hematemesis. And then dark red blood or dark red vomit would be profuse bleeding in the stomach, usually from a perforated ulcer. Coffee ground-like vomit, it usually indicates less severe bleeding in the stomach or old bleeding because the gastric acid has had time to actually change the composition of the blood. So this usually indicates older bleeding. Yellow or green emesis suggests bile. This indicates that the pyloric valve is open and bile is flowing into the stomach from the duodenum, and this tends to be more common in older people. Complications, nausea and vomiting is usually and hopefully short-lived. If it's prolonged, we know that it can cause weakness, we know it can cause weight loss, dehydration, and electrolyte imbalances, dental problems, esophagitis, prerenal azotemia, cardiac arrhythmias, esophageal tears, etc. Many things can be complications of vomiting and nausea. So the treatment, nursing interventions, we want to ask some key questions like how long has this been going on? What is the relationship to meals? What do the contents of the vomitus look like? Do you have any associated symptoms like pain in the chest or abdomen, fever, any muscle pains, diarrhea, vertigo, dizziness, headache, any focal neurological symptoms, jaundice, weight loss, anything else going on with the nausea and vomiting. We also want to ask if they have diabetes. We want to ask women when their last menstrual period was, in case they're experiencing pregnancy-induced nausea and vomiting. We also want to know about recent travel and recent foods that they've eaten. Have they eaten any raw fish, shellfish? And then we want to assess their vital signs. And we want to treat them. We want to replace volume and electrolyte deficits if need be. Usually we will keep them NPO and replace volume with IV fluids. We'll carefully monitor their intake and output. We want to prevent aspiration, so of course we'll turn them on their side and make sure we have suction available. Try to figure out what the underlying cause is and hopefully treat that. And of course provide, symptomatic relief, either some type of antiemetic, either usually not by mouth if they're vomiting, but IM, intravenous, or even a rectal suppository. After someone's vomited, it's good to provide them with oral care. And of course, once they start eating again, we can look at their nutritional deficits. And then, if they can start eating, progress their diet as tolerated, start with clear liquids and advance from there. So let's talk about gastroesophageal reflux disease, also known as GERD. This occurs as a result of the backward flow or reflux of GI contents into the esophagus. Normally, whenever the stomach contracts, it also closes off the esophagus instead of squeezing stomach acids into it. This prevents the reflux of gastric acid. So let's look at this case study. MR is a 56-year-old general contractor who is admitted to your telemetry unit directly from his internist's office with a diagnosis of chest pain. On report, you are informed he has an intermittent 2-month history of chest tightness with substernal burning that radiates through to the mid-back intermittently in a stabbing fashion. Symptoms occur after a large meal with heavy lifting at the construction site and in the middle of the night when he awakens from sleep with coughing, shortness of breath, and a foul, bitter taste in his mouth. Recently, he has developed nausea without emesis, worse in the morning or after skipping meals. He complains of heartburn 3 or 4 times a day, and he takes a couple of Rolaids or Tums. He keeps a bottle at home, at the office, and in his truck. His vital signs are 130/80 lying, 120/72 standing. Heart rate is 100, respiration's 20, temp 98.6, and his SAT is 92% on room air. So, given that scenario, so what signs and symptoms is MR having that would be suggestive of gastroesophageal reflux disease? Out of these, go ahead and think about what 5 answers you would pick. I'll give you 30 seconds, starting now. Okay. Hopefully you picked dyspepsia, cough, regurgitation, chest pain, and nausea. Okay, Mr. or MR has smoked 1 pack of cigarettes a day for the past 35 years, drinks 2 or 3 beers on most nights, and has noticed a 20-pound weight gain over the past 10 years. His favorite foods are chips and spicy salsa, pizza and chocolate, and he feels so tired and old now. MR has dark circles under his eyes and complains of daytime fatigue. His wife is even sleeping in another bedroom because he is snoring so loudly. He also re-injured his lower back a month ago at work lifting a pile of boards, so his physician prescribed ibuprofen 800 milligrams twice a day or 3 times a day for 4 weeks. What risk factors does MR have for the development of GERD? Go ahead and think about 3 of these answers. Give you about 10 seconds. All right. Hopefully you picked obesity, ETOH or alcohol consumption, and smoking. Other risk factors would be things like hiatal hernia, pregnancy, any diseases that affect muscle tone or neuromuscular function, consumption of a diet that's high in fat or spicy foods, and also things including chocolate, citrus, and tomatoes. All right, the most accurate method of diagnosing GERD is esophagogastroduodenoscopy, 24-hour ambulatory esophageal pH monitoring, patient complaints of dyspepsia after eating, or esophageal manometry. I'll give you a few seconds to think about that. And hopefully you all picked 24-hour ambulatory esophageal pH monitoring. So that is the most accurate. Other tests that they can do are esophagogastroduodenoscopy and esophageal manometry. So one of the main complications of GERD is reflux esophagitis, where the inner lining of the esophageal wall becomes damaged by prolonged exposure to the stomach acid. The first sign of esophageal damage may be redness or friability of the esophageal mucosa that indicates inflammation. And then eventually there will be the appearance of erosions. What complication of GERD is associated with an increased risk for cancer? Adult onset asthma, obesity, aspiration pneumonia, or Barrett's epithelium. Take a minute, and hopefully you all picked Barrett's epithelium. This is also called Barrett's esophagus. This is severe long-standing GERD, can actually damage the esophagus, so the normal lining of the esophagus, which is normally squamous mucosa, is actually replaced by a lining that's more like the stomach or the intestine, which is made out of columnar epithelium, and this is considered pre-malignant in the esophagus. And theory is that it may be an attempt by the body to protect itself from further injury by acid, and the thickening can also lead to esophageal stricture, so patients may have difficulty swallowing. So what would the nurse teach MR regarding nutritional therapy and lifestyle changes? Well, some of the nutritional therapy is covered in your textbook, eating 4 to 6 meals a day, limiting fatty foods, coffee, tea, cola, and chocolate, decreasing spicy foods that may increase gastric acid, and also limiting things like coffee, tea, cola, carbonated beverages. And again, like I said before, spicy tomato products, citrus fruit products, peppermint, onions, and no food generally 2 to 3 hours before bed. And usually they recommend that patients stay upright for 1 to 2 hours after meals. As far as lifestyle changes, elevating the head of the bed generally for sleep, they recommend up to 6 inches. Sleeping in a left lateral decubitus position. The book says the right side, which is not correct. It is the left side. reducing weight, wearing non-binding clothing, refraining from lifting heavy objects, straining or working in a bent-over position, avoiding alcohol, caffeine, smoking, and NSAIDs. And as far as treatments and medications, Susan will discuss this with you in PHARM. What procedure is considered the gold standard for surgical management of GERD? The Stretta procedure, the Nissen fundoplication, vagotomy, or pyloroplasty? Take a few seconds to think about that. And the answer is, hopefully you thought of, Nissen fundoplication. So fundoplication is the most common anti-reflux surgery, and this is where the gastric fundus, which is the upper part of the stomach, is wrapped or plicated around the lower end of the esophagus and then stitched in place. And this simply reinforces closing of the lower esophageal sphincter. This can be done open, it can be done laparoscopic, or it can be done actually through an endoscope. So other non-invasive procedures that are done through an endoscope are the Stretta procedure, which is radiofrequency energy that's applied to needles near the gastroesophageal junction, and this decreases vagus nerve activity. And then gastroplication, which is the lower esophageal sphincter is actually tightened using sutures. And then also vagotomy and pyloroplasty are not used for GERD. Go back to this. What is a hiatal hernia and what is its role in GERD? Well, hiatal hernia is actually protrusion of the stomach through the esophageal hiatus, which is the opening of the diaphragm into the chest. And you can have a sliding hernia, which is the most common, and that occurs when the esophagogastric junction and a portion of the fundus of the stomach slide upward through the esophageal hiatus into the thorax, and this is actually the most common. Or a rolling hernia where the fundus rolls into the thorax beside the esophagus. Signs and symptoms are heartburn, regurgitation, pain, dysphagia, belching, and worsening symptoms after eating or when in a lying down position. Most hiatal hernias, however, are asymptomatic and they're just discovered incidentally. Rarely they can have life-threatening complications such as a gastric volvulus or strangulation. So how do we treat hiatal hernia? Well, through drug therapy, which Susan will talk about, usually antacids, H2 receptor blocking agents, and proton pump inhibitors. Nutrition therapy, again avoiding eating in the late evening and avoiding foods that are associated with reflux. Weight reduction, elevating the head of the bed 6 inches, very similar actually to GERD lifestyle changes. Remaining upright after eating, avoiding straining, vigorous exercise, and avoiding non-binding clothing. Surgical management, majority of patients who would have undergone surgery in the past are actually managed successfully today with proton pump inhibitors. The other one would be fundoplication, where the esophageal hiatus is actually narrowed down by sutures. Okay, MR is now diagnosed with gastritis. What is gastritis? Well, gastritis is defined as inflammation of the gastric mucosa. There's 2 types, acute and chronic. And with chronic there are some various types. What bacteria is generally responsible for causing acute gastritis? E. coli, H. pylori, Salmonella, or Streptococci? And hopefully you all picked H. pylori. H. Heliobacter pylori is actually a gram-negative spiral-shaped bacterium. It thrives in the acid environment of the stomach, and it most likely is acquired by the ingestion of contaminated food or water and through person-to-person contact. Approximately 20 to 30% of the adult population in the United States is infected with the bacteria. Other causes of gastritis: alcohol consumption, radiation, smoking, NSAIDs, food poisoning. What are the clinical manifestations? Gnawing or burning ache or pain in the upper abdomen may become either worse or better with eating. Nausea, vomiting, loss of appetite, belching or bloating, feeling of fullness in the upper abdomen after eating, and weight loss. So the treatment of gastritis, again, similar to GERD, identify and eliminate the cause, drug therapy, diet therapy, stress reduction, and surgery. So a patient scheduled for a vagotomy asks the nurse what a vagotomy is. Which of the following statements by the nurse best describes the purpose of the vagotomy? It decreases food transit time in the stomach. It regenerates the gastric mucosa. It reduces the stimulus to acid secretion. It stops stress-related reactions. Hopefully you picked reduces the stimulus to acid secretion. So vagotomy is the cutting of the vagus nerve to decrease acid secretion. Other surgical procedures would be a partial gastrectomy, a pyloroplasty to enlarge the pyloric sphincter, and then total gastrectomy would be the last-ditch effort. So MR is now diagnosed with peptic ulcer disease. What is peptic ulcer disease, and what most likely was the cause for MR? Well, peptic ulcer disease is an erosion in the lining of the stomach, which is considered a gastric ulcer, or the first part of the duodenum. Stress ulcer are gastric ulcers that occur with physical stress like major surgery, traumas, or burns. Causes are long-term use of NSAIDs, but usually H. pylori infection is one of the main causes. Psychological stress and spicy foods do not cause ulcers, which they used to believe did, but they actually can make an ulcer worse. And this shows you where the different locations of peptic ulcers are. Signs and symptoms: they may have no symptoms, they may have upper abdominal pain, they may have feeling of fullness, weight loss, chest pain, fatigue. So back to our patient. MR begins to complain of nausea, and as you hand him the emesis basin, he promptly vomits coffee ground emesis with specks of bright red blood. His vital signs remain stable. And as you recall, coffee ground emesis simply means it's blood that has actually started to clot. It's old blood. It's not generally indicative of fresh bleeding. And in this slide you can see the different areas of GI bleed: esophageal cancer, gastritis, gastric ulcer, gastric cancer, duodenal ulcer. So you contact the gastroenterologist, consulting physician, to explain the recent events. The gastroenterologist gives you several orders and states he will be there in 45 minutes. The orders are as follows: NPO for emergent esophagogastroduodenoscopy, also called an EGD, stat CVC, O2 by nasal cannula, titrate oxygen to maintain sat over 90%, type and cross-match 2 units of packed RBCs, insert 2 large bore IVs, and start a normal saline at 100 mL per hour drip, and start a pantoprazole drip at 8 milligrams per hour, preceded by an 80 milligram bolus over 8 minutes. Insert a nasogastric tube and start a gastric lavage with water or saline. Okay, so let's explain the rationale for each of the following. We know that we want to get vital signs to check for hemodynamic stability, make sure their blood pressure is okay and they're not going into shock. We also want to check for orthostatic hypotension. Generally, a greater than 10 millimeter of mercury drop in blood pressure from lying to sitting or sitting to standing indicates a greater than 20% reduction in blood volume. We also want to keep the patient nothing by mouth because we don't know if the patient's going to need surgery or what's going to happen. We want to get a stat CBC to assess the level of bleeding, and bearing in mind that the initial hemoglobin and hematocrit may not reflect how severe of GI bleeding is going on. We also want to keep in mind that we will be doing frequent hemoglobin and hematocrits regularly, and that if we're doing them too much or too unnecessarily, that could also cause a drop in hematocrit. We want to get pulse ox and even an EKG in patients that may have a history of cardiac or pulmonary problems, and a little extra oxygen at this point, if they're bleeding, wouldn't hurt. It would probably help them. Type and cross match. Remember, a unit of packed RBCs contains about 300 mLs, and this should raise the patient's hematocrit level approximately 3 percentage points. So if there's no change after a transfusion of one or more units, they may have an ongoing hemorrhage. We want to insert 2 large bore, meaning a 16 or an 18 gauge IV line, or have the physician put in a central venous line. And we want to give immediate volume expansion with blood preferably, or if there's no blood available yet, then IV fluids, particularly isotonic fluids, normal saline. We want to give vasopressors if the blood pressure is not stable. We also would want to give IV protonics, pantoprazole. Usually we'll do a bolus and then we'll put them on a drip. And the reason most physicians like the proton pump inhibitors is because they're very good at keeping the gastric pH at a level above 6, which helps to protect an ulcer clot from actually breaking down. And this infusion is usually continued for 48 to 72 hours. We also want to give or consider octreotide IV drip for bleeding esophageal varices. The other thing that most physicians will want is an NG tube inserted, and we want to lavage the stomach to see what's going on if there's still old blood there. But this is we only put the NG tube in after X-ray confirmation. We want to make sure that there's no free air in the abdomen, and we also, once we do get the NG tube in, we want to make sure that the NG tube is in the correct place. We certainly don't want to do any lavage or put anything down that NG tube until we're sure there is no perforation, because we don't want to be pushing normal saline into the gut and there's a perforation where it's all going to go out into the peritoneal cavity. So X-ray to make sure there's no free air in the abdomen and that our NG tube is in the correct place. We do not want to do gastric lavage with ice water, which we used to do for years and years for a GI bleed, because they found it's actually dangerous due to rebleeding from rebound vasodilation after the cold water is stopped. So no ice-cold lavage. And then after the patient is stable, the physician will usually try to identify the source of the bleed. They'll get a complete history to try to determine, is this an H. pylori problem? Is this related to alcohol abuse? Is this related to NSAID use? And usually they'll do the EGD to identify the source of the bleed, and if necessary they can actually go in and stop the bleed at that point. This MR will have the esophagogastroduodenoscopy and EGD to attempt hemostasis. So, when providing care for a patient who has had an upper GI endoscopy, the nurse should include which of the following interventions: assist the patient to maintain a right side lying position, tell the patient to be on a clear liquid diet for 12 to 24 hours, keep the patient nothing by mouth until the gag reflex returns, or administer the prescribed bulk-forming laxative. And what do you think the answer is? Hopefully you guessed. Keep the patient nothing by mouth until the gag reflex returns. We do not want the patient to be aspirating. All right, moving on. MR's condition stabilizes and he is discharged home 3 days later. His physician suggests he has a colonoscopy since he has never had one, and in light of his recent situation. So, next question. Which of the following is correct concerning colonoscopy? It should be done beginning at age 50 for men and 55 for women, then every 10 years. Should be done beginning at age 45 for women and age 50 for men, and then every 5 years. It should be done beginning at age 50 for both men and women, and then every 10 years. It only needs to be done if there's a positive family history of colon cancer. And the answer is C. It should be done beginning at age 50 for both men and women, and then every 10 years. Polyps are discovered on MR's colonoscopy when he gets it done, and the physician informs him that polyps are actually small growths in the intestinal tract covered with mucosa, and they are attached to the surface of the intestine. They're usually asymptomatic, but they can cause gross rectal bleeding, intestinal obstruction, and intussusception, where the intestine kind of pulls itself or telescopes on itself. There are many types. The most common are polyps that become cancerous, and these are called adenomatous polyps or adenomas, and these account for about 75% of all colon types, of all colon polyps, Other types that will have, there are other types that actually do have no malignant potential. So, what polyp disorder will always lead to colon cancer? Familial adenomatous polyposis, FAP, pedunculated polyps, sessile polyps, or polypropylene indicolon? Alright, hopefully you guys picked A, familial adenomatous polyposis. And this disorder is actually very serious, and patients who have this will develop hundreds to thousands of colon polyps, which usually starts in their teens. All patients, 100%, will develop colorectal cancer from the polyps, and it's usually by the time they're 40. Patients with FAP must have the colon, sometimes the rectum, removed to prevent colon cancer. Nursing care, we want to teach our patients that starting at age 40, their stool should be tested for occult blood. We know occult blood means blood that can't be seen with the naked eye every year, and that polyps can bleed into the intestine where the blood mixes with the stool. So this is an early warning sign. Patients should have routine colonoscopies, and some physicians still want to do sigmoidoscopies, but the rationale is that the colonoscopy actually examines the entire colon, where the flexible sigmoidoscopy only examines the rectum and the colon adjacent to the rectum. And approximately 50% of colon polyps and colon cancers are found in the upper colon, the cecum, the ascending colon, and the transverse colon. And these are all out of reach of sigmoidoscopy, so they would be missed. And National Polyp Study was a large scientific study that showed colonoscopy with removal of all colon polyps reduces death from colon cancer. So what do we want to recommend for our patients as far as diet? That diets high in fat and low in fiber can predispose people to develop colon polyps. Certain vitamins, like vitamin C and E, actually help to protect against colon cancer. Cruciferous vegetables such as broccoli, cabbage, cauliflower protect against colon cancer. And NSAIDs such as aspirin actually reduce the formation of polyps, but it's not really advocated as a means to prevent colon polyps because of the other risks. So let's talk about hemorrhoids. What are hemorrhoids? They're painful, swollen veins in the lower portion of the rectum or anus. Internal hemorrhoids occur just inside the anus at the beginning of the rectum, and external hemorrhoids occur at the anal opening, and they can actually hang outside of the anus. They're very common, especially during pregnancy and after childbirth, and they result from increased pressure in the veins of the anus. And the pressure causes the veins to bulge and expand, and which can become very painful, especially with sitting. The most common cause, though, is straining during bowel movements, and this can result, of course, from constipation, sitting for long periods of time, and anal infections. This can also be caused by other diseases such as liver cirrhosis. Symptoms of hemorrhoids include anal itching, anal ache or pain, especially while sitting, bright red blood on the toilet paper or in the stool or toilet bowl, pain during bowel movements, or actually palpating one or more hard lumps near the anus. And how do we treat these? Usually with an over-the-counter corticosteroid cream or witch hazel, which, if you apply with cotton swabs, can actually reduce the itching. There's actually wipes now that have witch hazel in it for patients with hemorrhoids. You want to tell patients to avoid toilet paper that have any perfumes or dyes in it. Try not to scratch if they can. Sitz baths sometimes can help, and stool softeners will help to reduce straining and constipation. And if these treatments at home don't work, there's also things like infrared coagulation that will help to shrink them, or ultimately surgery where they ligate the hemorrhoids or they actually remove them with a hemorrhoidectomy. And they'll usually only do surgery if there is severe pain or bleeding and the patients haven't really responded to any other therapy. So how to prevent hemorrhoids? Prevent constipation, basically. Avoid straining, eat a high fiber diet, fruits, vegetables, whole grains, fiber supplements, etc. So let's move on and talk about genitourinary disorders, or GU disorders. We know the genitourinary system consists basically of our urethra, bladder, the ureters, and the kidneys. And in some cases, genital area such as STDs and disorders like that, which we will not cover in this semester. So the first one, the most common, cystitis. This is inflammation of the bladder. This is often caused by bacteria that move up the urinary tract from the external urethra to the bladder, and we call this a UTI. We know that catheters are the most common factor in the hospital setting, and 50% of patients in the hospital become infected within 1 week after a catheter insertion. And of course, we know that Medicare will no longer reimburse for any catheter-associated UTIs, or CAUTI. So it's really important that we as nurses try to get these catheters out as soon as possible. Signs and symptoms of cystitis: frequent urge to urinate, dysuria, urgency, abnormal urine color, cloudy, hematuria, blood in the urine, foul or strong urine odor, leakage of urine around the catheter, pressure in the lower pelvis. And then other symptoms that patients may state are chills, fatigue, fever, other signs basically of infection. Flank pain, mental changes or confusion, especially in elderly patients, vomiting, white blood cells in the urine, and then of course a urine culture is definitive. So the treatment, drug therapy is the mainstay, and urinary antiseptics, which are drugs that have antimicrobial activity in the urine, really little or no systemic antibacterial effect. And the usefulness is limited just to therapy and prevention of UTIs. Nitrofurantoin is one of the ones we use quite a bit for that. Also analgesics, antispasmodics, and antifungals, and then of course long-term antibiotic therapy if someone has chronic recurring infections, although we really are trying to stay away from antibiotics as much as possible, but we're still seeing antibiotics being used, of course, with urinary tract infections. Non-surgical management would be removing the catheters, of course, getting the catheters out and having patients urinate on their own. Diet therapy, we want to increase calories because of the patient's increased metabolism due to the infection. We want to increase fluids, usually 2 to 4 liters a day. Cranberry juice is preventative. Also pain relief measures, warm sitz baths, and generally the antispasmodics and analgesics also help. All right, urethritis. This is inflammation of the urethra that causes symptoms similar to urinary tract infection. These can be caused by bacteria, generally E. coli, or virus, oftentimes herpes simplex virus and cytomegalovirus, STDs such as chlamydia or gonorrhea. And other causes could be sensitivity to chemicals that are used in spermicides or contraceptive jellies, any creams or foams, also bubble baths, things like that, injury, and this is treated similar to cystitis. Urethral strictures. This is in narrowed areas of the urethra, usually due to scarring, infection, catheters, pelvic fractures, trauma. Men more than women tend to develop urethral strictures, and the most common symptom of this is obstruction of urine flow. Surgical treatment by urethroplasty is the best chance of long-term cure, is where they go in and actually dilate the urethra. And this is usually a temporary measure, unfortunately. So the different types of incontinence, most common are overflow, where there's some kind of blockage in the urethra and the bladder is unable to empty completely. Sometimes these patients will just have small amounts of urine leaking out. Stress incontinence, this is usually related to increased pressure in the abdomen, and this is a type of incontinence that you see when people cough or sneeze or laugh. And then urge incontinence is generally related to oversensitivity of the bladder, where as soon as the signal comes in, the patient can't resist the urge to urinate. Some causes of temporary urinary incontinence: alcohol. Alcohol is a bladder stimulant and a diuretic. Same with caffeine. Overhydration, people that simply drink too much water. Dehydration also can cause incontinence because the concentrated salts actually irritate the bladder. And then any other things that irritate the bladder, such as carbonated drinks, like I said, caffeine, tea and coffee, and actually with or without caffeine. Artificial sweeteners, corn syrup, foods and beverages that are high in spice, sugar, and acids, such as citrus and tomatoes, can aggravate the bladder. So medical conditions that are responsible for temporary urinary incontinence, think about diapers with add an extra P to it. So delirium, which we know is often temporary, short-term, unlike dementia that's long-term. Infections such as UTIs, atrophic urethritis and vaginitis, which tends to occur after menopause. Pharmaceuticals, certain medications, of course, diuretics, cholinergics, sedatives, muscle relaxants, psychiatric disorders such as depression, people that have excess urine output, say because of diabetes, so they have polyuria, patients who have restricted mobility, and patients who have stool impaction, putting pressure on the bladder. So causes of persistent urinary incontinence: pregnancy and childbirth, changes with aging, patients who have had hysterectomy, interstitial cystitis, prostatitis, enlarged prostate, oftentimes secondary to benign prostatic hypertrophy, also called BPH, prostate cancer, bladder stones, and neurological disorders as well you can add to that. And these would be things like stroke, Parkinson's disease, multiple sclerosis, also diabetes because of the nerve damage from diabetes. Treatment depends on the type of incontinence and the severity of the problem and the underlying cause. Bladder training, where they teach patients to hold their urine for 10 minutes at a time and then increase that time. Have patients do scheduled voidings, like every hour or 2 hours, taking them into the bathroom. Physical therapy that can help with pelvic floor muscle strengthening and actual electrical stimulation. Medications such as anticholinergics. Estrogen will actually tone and rejuvenate the tissues in the urethra. antidepressants to treat mixed urge and stress incontinence, medical devices that can be inserted. Also, sometimes they're called pessaries in the vagina, and that helps to hold up the bladder, or vaginal cones, and surgery. Pyelonephritis. This is actually caused by bacteria or virus, oftentimes E. coli, that travels on up from the bladder and is now infecting the kidneys. This can be chronic or acute. So the risk factors for pyelonephritis: patients who have a bladder infection, those who may have structural or anatomic problems in the urinary tract, such as a vesico-ureteral reflux. This is where urine, instead of going down, some of the urine will actually go back up into the ureters and then into the kidneys. This is more common in children, but you do see some adults with it as well. Signs and symptoms of pyelonephritis: fever, vomiting, backside and flank pain or groin pain. Flank pain is kind of just what you see here in this picture, this area, and kind of the back and towards the side. Chills, nausea, frequent and painful urination. So treatment for pyelonephritis is generally antibiotics, and oftentimes these need to be taken for several weeks. Surgery: if there's an abscess that can be drained, they may go in and put in a drain and drain out any infection, or they may actually sometimes have to remove the entire kidney, do a nephrectomy if it's just very resistant infection that they can't get a hold of. So generally, though, the treatment of choice, if it's a bacterial infection, are antibiotics, and oftentimes this can take a while to cure. All right, well, thank you. That was the end of your last class. I hope you've enjoyed it, and I think you're all ready to move on to next semester. Take care.